It is, it really is, and most of these actually, the published literature is equinus. You can really tell most of the modes that, as I said yesterday, as in with black box modes, with these artificial brains, the AANOS, you can't really tell what's going on inside. If you can't tell what's going on inside, and they don't report on like the confusion matrix and just tell you, hey, it's got great performance, how are you going to know as a reviewer or even a reader?
Great, thank you.
All right, up next we have Dr. Robert Minion, Demark, and he's visiting from Sioux Falls, South Dakota, and we appreciate you presenting today.
Yeah, thank you. Thanks for having us. Like on behalf of my students, thanks for the South Dakota additions here. So we'll get started here. Oops. So my topic today is talking about carpal tunnel syndrome and give you an update of what's going on. The alternative title I stole from John Fowler, Nerve Conductive Studies for Carpal Tunnel Syndrome, Gold Standard or an Unnecessary Evil. I have no disclosures. So we'll talk about carpal tunnel, how to diagnose it, what is a CTS6, and do you really need nerve studies for carpal tunnel? So we'll stick just to the facts today. And you're probably wondering what's up with this talk, because what could possibly we do about carpal tunnel syndrome? After all, first described in 1854 by Paget. Fast forward to 2024, a Google search, there are over just about 200,000 sites for carpal tunnel. And it's an interesting history from Paget. We went to 1880 Putnam, described 37 patients. In 1893, Schultz in Germany described acroparesthesia. And in 1924, the first carpal tunnel was done by Galloway. And in 1946, Can and Love at the Mayo Clinic described tardy median palsy. But as of 1950, there were only 12 reported cases of carpal tunnel surgery done. And that all changed in 1950 with George Phelan, who published several articles about median nerve compression at the wrist. And in 1966, published his landmark article of 654 hands with carpal tunnel. So this is a clinical diagnosis based on the history and physical. And in fact, you can even make this diagnosis over the phone, just give the patient a chance to tell the story. It's more common in females. Numbness in the median nerve distribution, typically night pain and numbness, aggravated by driving a car, talking on the phone, and reading a newspaper. It's a very common problem, estimated 400,000 carpal tunnel surgeries done every year in the United States, with a total cost of $2 billion per year. And we're all familiar with the median nerve, both the motor component and the sensory distribution. Physical examination has always been a two-point discrimination, although that's really a late finding in carpal tunnel, and probably the Sims-Weinstein is a more appropriate test for that. But for motor testing, we can look at the thenar muscles and tensile strength. We're all familiar with the Phalens and the Tenels. I usually do the Jerkins, which is compression in the median nerve at the wrist crease. And we always have to think about other problems like cervical disc disease, typically C6, and that's the sensory distribution of C6 in the hand. The other differential diagnosis is what's called Lacerda syndrome or pronator, and we'll talk about that later today. We should mention electrodiagnostic studies. What are they? What are the indications? And are they needed for idiopathic carpal tunnel? Chris D. wrote a great review article in the Yellow Journal a couple years ago talking about nerve studies and described two components, the NCB, basically for nerve evaluation, and the EMG to evaluate the resting membrane potential. And the purpose has been confirmatory in the past and as a screening tool, although I think I would discourage people from using this on a fishing expedition. So clinically, carpal tunnel is used, cubital tunnel, cervical reticulopathy, and peripheral nerve injury. And just how good are they in testing for carpal tunnel? Sensitivity is between 82 and 85%. Specificity is 95 to 99%, although there's a false negative rate of 20%, perhaps even higher. And for cubital tunnel, the sensitivity is a little bit wider from 37 to 86%, and specificity greater than 95%. his article, he points out the sensitivity for both carpal tunnel and pupil tunnel. NCV is much more sensitive than EMG for carpal tunnel. If you do nerve studies at our place, it costs $1,000 to get one done. It means extra visits for the patients and leads to delayed treatment for 3 to 4 months because they can't do a nerve test. So what is a CTS-6? And this is a new thing you should be aware of. This is a diagnostic questionnaire that was first published in 2008 by Frank Graham, looking at the added value of electrodiagnostic testing. And his consensus was that it really did not add any probability of diagnosing carpal tunnel. This is from the articles at 6 questionnaire. This is my copy of my dictation booth. And it really has 6 parts with points. History and symptoms have 2 parts. Numbness in the median nerve distribution and nocturnal numbness. And the physical has 4 parts. Pain or atrophy or weakness, a positive phalanx, loss of 2-point discrimination, and a positive channel sign. And so you can add up your score after you examine the patient. If you have 12 or more points, you probably have carpal tunnel. And this is from this article showing the increase in number of points increases the probability of diagnosing carpal tunnel. And this is a pretty reliable test. This group had some patients examined by medical students, OTs, and hand surgeons, and they found substantial agreement in the exams. So anybody can do this test. It's not real hard. And diagnostic testing has kind of been the new hot button now in the hand world. Probably the best document was published by the American Academy on the Management of Carpal Tunnel Syndrome. This is 2016. They had a large work group that worked for years, generated 986-page document about carpal tunnel, which you can download for free, fortunately. It's a PDF. And their consensus after going through all the literature was that there's moderate evidence to support that a diagnostic questionnaire like the CTS-6 and or electrodiagnostic testing can be done to diagnose carpal tunnel. So you don't need to do a nerve test. And this has changed, I think, the way things are being done. This study looked at the number of nerve studies done from 2016 on have dropped dramatically. So I think people are using more of the CTS-6. Who orders the nerve studies? Primary care leads the way, followed by neurology, orthopedics, hand surgeons, PM&R, rheumatology, and a group of others. You could name. So, and this is a great survey that was done on the Hand Society. They had 770 hand surgeons respond about the clinical practice guidelines. So 26% of these surgeons require a nerve study before they see the patient. And 56% would between an order a nerve study if it wasn't done already. So 82% of these physicians won't see a patient without a nerve study, which of course flies in the face of the clinical practice guidelines. And then the best part is 38% felt that the clinical practice guidelines are appropriate, but 43% didn't know what the guidelines recommend. So if I were a member of the committee, I'd be a little perturbed by that. That message was not received. We should talk about ultrasound versus nerve studies. This is a great paper by John Fowler comparing ultrasound and electrodiagnostic studies. They measured the median nerve in the canal. A normal nerve is less than 10 millimeters squared. Prominent is 10 to 14 millimeters squared, and abnormal is greater than 14 millimeters squared. And they did a head-to-head comparison of ultrasound and electrodiagnostic testing. Sensitivity and specificity were the same for both groups, as was a positive and negative predictive value. So the conclusion was that this is a high sensitivity, specificity, and accuracy in a group of patients with a positive CTS. And Fowler took this one step further. He compared the size of the median nerve to the electrodiagnostic testing severity and found a direct correlation with the severity of the nerve testing. So a normal nerve study, nerve is less than 10 millimeters. Mild carpal tunnel is 10 to 12. Moderate is 12 to 14, and severe is greater than 14. And the other advantage of using ultrasound versus nerve studies is it requires fewer medical visits, and people can have surgery earlier than with nerve studies. So this is a lot to think about, I think, for the average guy or girl. Future developments, I think we're going to be seeing more ultrasound-guided carpal tunnel injections, or releases, I mean. They have several products on the market. This is from the Mayo Clinic website showing their technique for ultrasound-guided carpal tunnel release. And after all, we are trying to improve patient care as we go along. We're all familiar with the value equation of Michael Porter, where value is defined as quality divided by cost. And we are talking about a lot of money with this diagnosis. And quality really is comprised of outcomes plus the patient experience. So I think if we can save money and not subject patients to EMGs, I think they'll be appreciative of that. And after all, I think this will probably transform the way we take care of carpal tunnel patients. So just to review the CTS exam, test your sensation, Chanel's, Phelan's, I always do the Durkin's, and then looking at the thenar muscles for motor exam. And I'm more of the Jack Sparrow school of thought as far as guidelines, not so much rules. So I think if you have a patient with a classic carpal tunnel story and a classic CTS6, I think all you need to do is a CTS6. If you do a nerve study, probably an NCV is probably enough. I think there are room for advanced studies. I think people with cervical disc disease, questionable neuropathy like diabetes or ALS, nerve injury, recurrent nerve compression, failed surgery, and non-clinical picture like AIN is probably justified to do that. So the conclusions, I think we know this is the most common compression neuropathy we see. It's a clinical diagnosis. I think the CTS6 has become more important as we go along. If you do want to do nerve testing, is it worth the added expense and delay in surgery? And I think the ultrasound and the CTS6 is going to be perhaps become the new norm, and it may become the new gold standard. So back to my question, do we need nerve studies for carpal tunnel? I was working on this talk, and I had a kind of a back to the future moment. I came across a paper written by George Phelan in 1981. He kind of detailed his story of carpal tunnel and how it came about. And it's interesting, he has a statement about what he thinks about nerve studies, and that these uncomfortable, expensive tests should not be required for every patient. And that was 43 years ago, and it's probably still a true statement. So we'd like to have you think about joining the CTS6 crowd. I think you'll be happy, and your patients will be happy when you make that decision. And if you do nerve studies, just don't make a fishing trip. Thank you. Any questions?
From the authorization standpoint, did you get any feedback that you don't have any support in their studies?
Yeah, then you have to do it. Yeah, I mean, that's what you do. And you would think the insurance companies would figure this out, but I think if you're really cynical, I think the longer they can keep doing nerve studies and have that 20% false negative rate, it's a money maker for them, I think. Yes?
But it's not only the insurance companies, it's also the institutions. You know, I remember when I was still working, I couldn't book a carpal tunnel without having, you know, they wouldn't let me book in the OR without having the studies.
No, not anymore.
Yeah.
We do it in the office, came out of that.
So this is not strictly related to testing, but from time and again, we see people who meet the CT6 criteria, but they also have these vague symptoms, you know, proximally radiating pain, my shoulder hurts, they've got nothing else going on, you know, it's an upper limb symptom.
Right.
How do you deal with these patients? Do you tell them that their hand symptoms will disappear after surgery, or what do you talk about these proximal symptoms? You know, my elbow hurts, you know, I have shooting pain going up. What do you tell them if they're going to have surgery?
Typically, I would even, for that patient, perhaps even do a carpal tunnel injection, ultrasound guided.
Yeah.
And you can see the size of the nerve. It's kind of a 2-for-1 deal, plus see how much relief they get from symptoms. The other thing, this may be my next talk, it may be the service for pain.
Sure.
For medium nerve, so. Yes?
Is there variability in the size of the nerve based on the size of the patient? I mean, do you look at the contralateral side, or like that, those numbers are just kind of interesting.
I think that's pretty much what it is, yeah. I haven't seen anything as far as comparing different arms.
I just kind of
think it is. Great, thank you.
Very good, thanks, Dr. Denmark. Next up, we have Andrew Alcazar, and thank you for presenting today from Chicago, Illinois.
All right, hello everyone, my name is Andrew. I come from Loyola University, Chicago. You can't tell, there's a huge coat of arms there. Today I'm going to be presenting on differential heparin neutralization studies using protamine sulfate and a novel synthetic peptide. So I'm sure we all know what heparin is. It's a pretty common drug that we use in surgeries, especially cardiac. But heparin is a variable length glycosaminoglycan that binds to antithrombin 3. And antithrombin 3 is a certain protease inhibitor that primarily possesses anti-2A and anti-10A activity. Clinically, this manifests as higher APTT, ACT values, and smaller amplitude values in thromboelastography, which you will see in the coming slides. Using heparin can be a little bit tricky. Bleeding after heparin can be a problem, so protamine sulfate is a naturally derived protein that's indicated for reversal of various types of heparin. In the case of heparin rebound, when protamine doesn't work, you just use more protamine. So an example structure of protamine I got from an ACS Omega paper has a very arginine-rich structure here. All protamines, in fact, are arginine-rich compounds. They're found in multiple species in sperm, and it's, in fact, used for DNA packaging. And this is precisely a good characteristic for also binding heparin. The reason why is that heparin has a high number of negatively charged sulfate moieties. Protamine, since it is arginine-rich and that at physiological pH makes it quite possibly charged, can bind to heparin. So you can see here from this nice little diagram. I think I have here we go. There's a nice little diagram here that I got from a random Twitter post. You have protamine binding to heparin, and basically it sequesters it from antithrombin 3. Now, heparin increases the activity of antithrombin 3 quite a lot, and so when there is no heparin to bind to AT3, you don't get inhibition of mainly factor 10A and 2A, and so clot formation is then permitted. So there are quite a few problems with protamine. Protamine can induce pretty adverse reactions, which I will be talking about in the next slide. Additionally, supply of protamine can be limited. I will also be talking about that in a second. Protamine can either be separated from salmon sperm or it can be recombinantly produced. And then in 2021 and 2023, Fresenius Kabi reported production issues for protamine, and you can find those letters online. So with that track record, it's a little bit worrying with our supply here. So some of the adverse reactions I was referring to, you can actually read in literature. Some of those reactions include bronchospasm, severe hypotension, bradycardia, and pulmonary vasoconstriction. Literature reports that this sort of occurs around 0.06% to 10.6% of the time, although people have different estimates about that. In addition to that, there's also literature that cites mitochondrial injury, and so I'm sure there's quite a bit that we don't know that it does at other levels. One report that I found in the 85 paper was of a 55-year-old woman with diabetes, a history of hypertension, and a host of other issues. She presented to the hospital with chest pains. She was recommended to stay, and on the 4th day of stay, she received a cardiac catheterization for a cardiac angiogram, coronary artery angiogram. And during that, she was administered 5,000 units of heparin and then 20 milligrams of protamine to reverse the heparin at the end of the procedure, which resulted in severe hypotension and bronchospasms. Thankfully, they were able to perform rescue measures and she had a full recovery. The next case was pretty bad as well. A 65-year-old man, also with a host of different issues, presented to the hospital with foot ulcers. As a quick note, previous administration of protamine didn't result in any sort of adverse reaction. This was 5 years earlier. So during the visit, they noticed bilateral carotid bruits with otherwise normal expiration heart sounds and abdomen, and they also found a total occlusion of the left superficial femoral artery. So they recommended a fem pop bypass graft, and they performed it with 10,000 units of heparin. By the end of the 45-minute procedure, they gave 50 milligrams of protamine over a period of 5 minutes, and this resulted in wheezing and cyanosis. He had a very low systolic pressure of 50 millimeters of mercury, and he was severely bradycardic. Thankfully, they were able to bring him back after intubation and also giving some vasopressors. So the question is, how do we solve the problem? Well, this novel synthetic peptide that I'm referring to is actually commercially available. It's called Heparin. It's produced by Aniara on behalf of 5 Diagnostics. Here's some positives about it. One, it's a homogeneous single peptide as opposed to protamine, which kind of comes in a mix of different sort of, not isomers, but different forms. It's lower in molecular weight compared to protamine. It sits at around 3.12 kilodaltons. Protamines, I believe, are usually around 4 to 5. This could be less immunogenic compared to protamine. It tends to be that heavier drugs do produce immune reactions. It's also a synthetic compound, so we don't have to derive it from anywhere. We can just synthesize it ourselves. And it can also be a possible alternative for those with intolerance to the protamine-heparin complex, which is what literature suggests is the source of these immune reactions. So the purpose of this study was to compare Heparin, which is the novel heparin antagonist, to protamine sulfate in a variety of conventional assays. As I mentioned, Heparin was originally developed as a laboratory reagent. It's not a pharmaceutical. To reverse heparin within blood and plasma samples. I think it can be developed within the clinical arena if we give it the chance, because honestly, we need more options for reversal. So our hypothesis for this study was that Heparin probably would have comparable reversing potential gram for gram as protamine sulfate, which we will take a look at right now. So we have the results. The methodology was to use, to compare Heparin in neutralizing heparin to protamine in thromboelastography, see like activated clotting time, APTT, and thrombin generation, which I know is not a commonly used clinical assay. I will explain it when we get there. Okay. So firstly, thromboelastography. So the setup for this was to draw fresh blood from willing participants, and we put them in citrate tubes. We then partitioned the blood into 4 TEG cups, and we had 4 different sort of combinations. So firstly, we had a saline sample. This was just blood mixed with saline. We had porcine heparin with protamine. The porcine heparin was set at 1 microgram per mil, same with the protamine. And then we had porcine heparin plus saline, and then porcine heparin with 1 microgram per mil of Heparin. So as you see here, this is a nice little clot. This is pretty usual for clotting. You see this nice wide amplitude. With protamine, there is a partial reversal. It did pretty well. It took a little bit longer to clot, but this is expected. And this one we were a little bit surprised by. At 1 microgram per mil, the Heparin didn't quite do anything, actually. You can see that it's overlapping with the saline line. So just to confirm that that was correct, we actually performed it a second time, and it yielded a similar result. So just to make sure that our Heparin was actually working, we dosed it at 10 micrograms per mil with 1 microgram per mil of heparin, and as you can see here, it took a little bit longer to clot than the protamine, but it still did its work, and it got to a similar amplitude. Next, we performed activated clotting time. So with this, we again drew fresh blood. We treated the blood with 10 micrograms per mil of heparin and 10 micrograms per mil of reversal. We also had just a saline, which was the baseline clotting, so this usually sits around, for most people, around 120, maybe up to 140 seconds. And we also had a saline plus heparin sample. So with the bovine heparin, you can see the Heparin, which is the red, did quite well. Protamine is green, and so it did pretty good with the reversal. This is just the saline and heparin. Ovine, it also did particularly well. Protamine sits down here. This is Heparin. The porcine sample was surprising. We had here a very wide distribution of clotting times. Protamine did well, but Heparin was quite all over the place, and this is probably because we were only able to perform this in triplicate. It is a little bit hard to ask people to just voluntarily give their blood. So I would say if we had a larger population of people, we would probably see more of a significant difference between this heparin saline combo and the heparin combo. Next, we perform thrombin generation. I promised I would explain this. So thrombin generation is a application of fluorescent spectroscopy. You put in a fluorescent dye. In this case, we have a 7-amino-4-methylcoumarin fluorophore that's attached to an oligopeptide, and then that binds to active thrombin. Over time, you can see, you can do some nice little calculations to figure out the active concentration of thrombin, and you get these nice little graphs that we call thrombokinetograms. Okay? All samples were treated with concentrations of heparin ranging from 0 to 2.5 micrograms per mil to sort of give a dose-response curve, which you will see in a moment. And samples were treated with a constant 2.5 micrograms per mil of reversal or just saline by itself. And this was measured over a period of 90 minutes. So this is the dose-response curve I was talking about. I don't really want to focus on the raw graphs. These correspond to the tops of these thrombokinetograms here, so the peak thrombin. And so you can see they correspond quite well to the reversal. So this blue line here is the saline plus the heparin. You see this nice little descent. As you increase the concentration of heparin, you would expect that the thrombin concentration would go down. With the reversals, you see that there's a resistance to the decrease in peak active thrombin. With heparin remove, it did quite well. However, you can see for all heparins, there was a significantly different potency compared to the protamine. That being said, it did perform quite well, and so I think it was quite impressive. Lastly, we performed activated partial thromboplastin time. Again, with this, pooled blood bank plasma was treated with varying concentrations of heparin and 2.5 micrograms per mil reversal. Same setup as the thrombin generation. Heparin remove and protamine both produce significant decreases in APTT, as we would expect. Right here we have for all of them, the blue line corresponds to the saline sample plus heparin. Here we have heparin remove for the bovine, ovine, and then porcine. Again, porcine, since it is such a potent heparin, it does, require a bit of a higher dosing with the heparin remove, but nonetheless, it still did show quite a reversal potential. So in conclusion, heparin remove shows a lower potency than protamine sulfate, as we saw in all those assays that I presented. This might be due to the fact that heparin remove also does inhibit factor 12. So there's kind of a competition between binding to heparin and then also binding to factor 12. Nonetheless, heparin remove could be a viable alternative to protamine within the clinical arena if we adjust it for potency. So just dose more of it, and it might prove to be quite similar to protamine sulfate. So with that being said, I would just like to thank Loyola University Chicago for allowing me to conduct this research. Additionally, I have no disclosures. And thank you. Any questions?
Thank you, Andrew. Appreciate it. Next, we have Dr. Sudhir Rao, and he is the chairman of the Academy. He'll be speaking to us on deformity correction in the hand.
How do you get the?
Down at the bottom.
Further down,
Further down.
to the right,
And to your right.
keep
now.
going, last one on the right,
Oh,
that's it.
Exactly.
all right. Good morning. It's going to be a little change in the presentation. This is going to be mostly clinically oriented, more pictures, less figures. So I'm going to talk about deformity correction in the hand, and I'm going to give you a list of cases starting from simple to complex. So orthopedics, as you know, comes from ortho, which is straight, and pedia, which is a child. And for the longest amount of time, orthopedics was concentrated with correction of deformity. If you look at the original emblem for orthopedics from Nicholas Andrew, it's this crooked tree which is trying to be straightened with physical means. And it was interesting to see that you can find a similar representation on Etsy. You can buy that online. And if you'd like to embellish your office with a new logo, that's available as well. So that was the basis for orthopedic treatment for the longest amount of time. And in the early years of orthopedics, most treatment was correction of deformity. We all see severe club feet deformity. In the older days, it was mostly treatment of deformities resulting from neuromuscular conditions. Polio was the big one, the big driver of treatment in the earlier days. But trauma and infection, especially tuberculosis, was also very prevalent in those days, and that really led to the genesis and progression of orthopedic surgery in the early part of the century. We all remember these days when children were treated with these cumbersome braces the longest amount of time. We don't see this much anymore, but those of us who've been around for a while remember these devices very clearly. I'm not certain if there is any spinal surgeon here who remembers these kinds of things, but they were very much in place 50, 60, 70 years ago. So a lot of orthopedic examination and assessment is really based on some of the older testing that we did clinically, and things like the Thomas test, Phelps-Baker test, Ober test, etc., all go back to the treatment of deformity resulting from polio and neuromuscular condition. If you really have to do a concise, precise clinical examination, you have to take into consideration things like limb-line discrepancy, pelvic obliquity. Is the deformity coming from within the joint or is it extra-articular? Are there intra-articular adhesions? Is this a neuromuscular condition? Is it spastic or is it paralytic? What is the contribution from the skin, muscle, tendon unit, bone, joint, etc.? These are precise clinical exams that one has to do when you assess a deformity. In today's day and age, I'm not certain how much emphasis is given to physical examination, but all of these things come from treatment of deformity in the traditional orthopedic sense. Fast forward today, if you look at how orthopedics has changed, if you look at total joint orthopedics, most of it is treatment of pain and loss of function. Sports medicine, which is extremely popular, again, is treatment of pain and loss of function. Most spinal surgeons, not all of them, are treating pain and loss of function. So deformity correction in the orthopedic world has taken a back row now. Most physicians and surgeons are treating pain and loss of function. However, in the pediatric world, in the hand and foot surgery world, you still see deformities, and that is still part of our patient pathology. So, since I do a lot of hand surgery, I figured let's talk about how we correct hand deformities, which sometimes can be a little different in principle from correcting deformity in the pediatric sense or in the foot surgery sense. So, first thing is, how do you define a deformity? And I would say that to different people or to different situations, stiffness, deformity, contracture can all mean the same or similar things. So if you have a situation where you're unable to place a joint or a part in neutral anatomic position, I would consider that to be a deformity. But at the same token, if you have a situation where you cannot put your joint to a full range of motion, that would be considered a deformity as well. Or if you have loss of normal anatomic alignment, that would also be considered a deformity. The things that you have to consider when you assess, define, and treat a deformity is it arising from the skin, from the tendons, joint, capsule, ligaments, or other neurovascular structures involved. And the restoration of deformity and function, especially in the hand, is you not only have to correct the deformity and alignment, but you have to consider things like range of motion, stability, and of course relief of pain. And sometimes when you try to correct one, you'll end up losing the other. So the goal and the trick and the ultimate aim is to try and give them everything possible, but sometimes you have to sacrifice one for the other. So when I assess a patient with a deformity in the hand, the things that I look at is, first of all, how do you define this deformity from an anatomic or functional standpoint? Do you correct the deformity in one or multiple stages? Do you concentrate on giving them the motion back, or is stability of the joint or part more important? I almost never get full function back unless it's a very simple thing. The question is, do you focus on giving them full flexion or giving them full extension? You always tell them that sometimes you'll end up losing one over the other. And as always, I tell all my patients, the surgery is the easy part, it's the aftercare that's really the challenge. So as I mentioned, deformity comes in many flavors. Sometimes it just involves one simple structure. Sometimes it's at multiple levels, and it can involve multiple structures as well. So what I'd like to do is to go from simple to complex and give you various case examples. So just by a show of hand here, this is a child with a fracture. Which of you would consider this to be a significant deformity, and who would treat this?
How's the patient?
6. Anyone?
No treatment.
You're asking what would we do, or?
Yeah.
Well, I know that we can accept that, but parents don't like it, I'd probably try to rush.
Okay.
Or chest.
All right. So I think that would be an answer many people give, but sometimes you can talk them out of it. And this is 2 months out. So I personally wouldn't do anything to it, but sometimes I agree with you. You're treating the parents and not the expert. Right. All right. So this is a simple deformity. Patient had severe gout and came to me with a finger. It's a fixed deformity, and they have pain. They're unable to extend the digit. In such a situation, they're really not concerned about restoring range of motion. I think it would be impossible to give this person full motion, relief of pain, and full stability. So the simple answer to this, in my book, would be to arthrodesis the joint and extension, and they do extremely well once it's healed up. So this would be a one-level, one-stage, simple deformity correction. You lose range of motion, but you gain relief of pain, and you have a stable digit. This is another common condition, a mallet finger. They jam their finger against a hard object, they rupture the tendon, and they come to you with a flex deformity of the distal joint. And most of these patients can be treated very successfully with an extension splint for about 6 weeks continuous. A small number of them do not heal and come to you with a chronic mallet deformity. So this is a situation where the person has extremely flexible joints, they don't heal very well, and they land up with what we call as the swan neck deformity. The central band of the extensor tendon overacts and causes hyperextension of the PRP joint. And sometimes they don't like this. This becomes untenable because they're not able to flex the digit very well. It gets in the way. And they ask you for some sort of surgical treatment. It appears practical and easy to try and repair that extensor tendon at the distal joint, but I can tell you, every single time I've tried to do that, you land up with some sort of a complication. The extensor mechanism in my hands is not an easy structure to deal with. You're looking at millimeter difference in length, which can cause serious changes in the range of motion and joint position. So I'm not that skilled enough to repair these anatomically, and I can't convince them that they will have a good outcome. So in my hands, if I have someone with a chronic mallet deformity, I do a central slip tenotomy under local anesthesia. They're awake. It's a very simple procedure. Once you simply tenotomize the central tendon, the whole extensor mechanism slides backwards, and instantaneously, virtually all of them, regain active extension of the distal joint. So I've had really good success with this really simple procedure. You do not have to repair or reconstruct the ruptured distal tendon. A Fowler tenotomy will almost always give them really good function.
Super. Why wouldn't everybody just do that?
I have no idea. This is an old operation, so sometimes they may not be aware of it, but it's been there for a long time. This again is extremely common, boxer's fractures. Kids get mad, they hit a wall, and then they realize they shouldn't have done it. This is an older person. Most boxer's fractures can be treated non-operatively, but if you have someone with a rotational malalignment of the finger, the digit crosses over when they flex their hands, and this is something that should be corrected. Again, it's a single level bone deformity corrected easily with internal fixation. So now we move on to something a little bit more complex. This is a minimally displaced proximal phalangeal fracture treated with percutaneous fixation. So you think that you've not violated tissue planes, you've done this percutaneously, they should do fine. They sometimes don't, and this patient landed up with severe flexion adhesions. She had full range of passive motion, but could not actively flex the digit. This is not something that typically gets better with physical therapy or time. You really have to go in, expose the entire extent of flexor tendon, do a complete genolysis. If you're lucky the flexor tendon is healthy, you don't have to do a two-stage procedure. In the old days, I used to be very fanatical about repairing the pulleys back. I'm not so sure it has to be done all the time, but in this case, I got away with it. We did repair the pulley, and she landed up with full active range of motion. So this is taking it one level further. You have to address not just the fracture, but you sometimes land up having to treat the tendon as well. So take it one step further, Dupuytren's disease, extremely common. In mild cases, it's never an issue. You can treat this in many different ways, including injection of enzymes or percutaneous fasciotomies. But in the more serious cases, I still believe that surgery is the way to go. And Dupuytren's disease affects the skin, the palmar fascia, and in my experience, the flexor tendon sheath and collateral ligaments are often affected as well. And in long-standing situations, you can have secondary changes in the extensor mechanism and the joint, and you land up with a complex situation where you have to attend to the skin, the joint, and the tendon. So the principles of treatment, of course, are the same. You have to try and achieve maximum correction without causing neurovascular compromise. If you operate on these people, it is imperative to have primary skin healing. You cannot, let the skin be the problem, because if the skin doesn't heal well, then you'll end up with delayed healing and recurrent contracture. So if you decide to treat these, you have to be able to treat the skin deficit if one is present. So that could mean just a simple skin graft or a local flap. And again, the trick is not the surgery, it's the aftercare. You have to correct the deformity and then maintain correction and also gain range of motion. Those two things are not mutually compatible. Sometimes, you'll end up losing one over the other. But the trick is to get both done simultaneously. So this is a standard severe Dupuytren's disease, where we do a complete fasciectomy. and do a Z-plasty to try and get some skin lengthening at the same time. The problem, of course, is if you have a severe contracture of the proximal interphalangeal joint, even if you get full correction at surgery, how do you maintain that correction? And also at the same time, make sure that they get adequate range of flexion. Those two things are always challenging to me. So once you do your full correction, with the skin, release of the joint, etc., the device that I use very often in severe PIP contractures is the digit widget. It's a little external fixator that you attach, to the middle phalanx, and it's got a little spring-loaded rubber band device on the dorsal, and you can use that to maintain dynamic correction, and at the same time they can release that rubber band and start active flexion. So you can get them to move right away, and at the same time, once you put that rubber band back, it snaps the finger back into extension. So it's like a mini external fixator that allows range of motion. So that's what it looks like when you apply it to the digit. So I'm just going to give you an example of someone who had a complex correction. This was an extremely severe small digit PIP contracture, and once you correct the deformity, there is a substantial skin defect. And if you leave this skin open, they will almost certainly get a recurrent skin contracture. So in my hands, I almost always do a rotation flap if I can't get a full thickness skin graft. And then if you apply the digit widget to the digit, once the skin has healed up in about 2 weeks, you can get them to move this finger. I leave it on for about a month or so, and then it gets pulled out in the office. Most of them are able to maintain really good correction. They'll end up losing a little flexion in the joint, but in the end, this is much better than just putting them in a cast or a splint for a few weeks. They always land up getting stiff. So the trick is, again, in Dupuytren's, once you correct the deformity, make sure they don't have a skin deficit. You have to keep them in full extension to maintain your correction, but at the same time, you have to keep them moving right away. So those two things have to be done simultaneously. And this device, the digit widget, really lets you accomplish both. So I'd like to move on to the neurologic hand. This takes it one level further. Most non-spastic neurologic hands have no real skin deficit. They have loss of muscle tone and active control. Most of them have supple joints, again the paralytic type. Usually they don't have fixed muscle tendon contractures. And the trick, of course, is to try and make it work with limited active donors. So here's an example of a child who had a brachial plexus tumor excised, and he had neurofibromatosis, and he had a severe claw hand deformity. And as we are all aware, when they have a severe intrinsic paralysis, they're not able to make a fist, they cannot grasp, they don't have pinch. So now you're trying to address multiple issues. And the way I addressed this one was to do a combined transfer for opposition and an intrinsic transfer as well. So we used the flexor digitorum sublimis from the ring finger to his thumb, and we used the classic brand transfer for his intrinsics. And again, this was a young child, supple joints. These folks tend to do extremely well. And if you look at him at 2 years, he had almost full correction of deformity. And the picture on the bottom shows you what it looked like before. And functionally now, he was able to make a fist, but extend his hands almost completely. And again, compare that to his preoperative hand on the right. So they tend to do well if you pick them early and do the right procedure. Okay, a little different here. If you have a rollover injury with severe loss of skin, tendon, bone, you've got to address multiple structures, and oftentimes you do it all at once. The trick again is to get a clean wound, do a radical debridement, and sometimes you can treat all of this at once. fix the bone, you can reconstruct the tendon and do a flap, get them covered. And if you have luck on your side, you will have correction of deformity, give them movement, and they have decent function. So, the rheumatoid hand is the holy grail, I think, of hand surgery. This is where you get to treat a whole complex variety of issues, starting from the skin, the joint, the tendon, the bone. And this is a progressive condition due to inflammatory changes. And as the disease progresses, the joint gets destroyed, the ligaments get stretched out, they start getting complex deformities, tendons rupture, so they lose active motion, and some of them land up having spontaneous ankylosis of their joints as well. So you have to treat multiple levels with multiple strategies. So these are some of the common deformities we see in rheumatoid hands. So the principles that one has to use, again, is you want to make sure that the proximal joint, that is the wrist, is in a stable, neutral position. If possible, you can retain some range of motion, but otherwise it has to be in a stable alignment. The distal ulna is often the culprit because that's what leads to multiple tendon ruptures, so you have to address that simultaneously. You want to make sure that the extensor and flexor tendons are intact. If they are ruptured, you have to sort of use that in your armamentarium when you plan your treatment. And again, the condition of the more distal joints is also important when you treat these patients. So some of the things we look at is, first of all, should you operate at all? Because many of these folks have severe deformity, but they have no functional limitations, so they can do stuff. So you just don't treat them because their hands look bad. You have to treat the function as well. Can you do this in one stage, or do you stage it in multiple procedures? Do you operate on all digits, or do you do some at a time? And of course, you have to take into consideration the more proximal joints as well. Are the shoulders affected? The elbows, are they able to walk without a walker? Do they need hip and knee surgery? So all these things should be taken into account. So again, a few examples here. So this is your classic rheumatoid deformity with flexion and ulnar deviation. This is mostly an MCP joint involvement. Tendons are intact. And these folks do extremely well if you just replace their joints and reconstruct the extensor mechanism. Take it one level further, this is someone who not only has finger involvement, but the wrist joint is completely shot. In my hands, I do a stage procedure here. It's a little bit too much to do everything at once. So, in the first stage, I stabilized the wrist joint, also stabilized her thumb, and at the second stage, we went in and fixed her MCP joints. And this is the same patient, post-operative. Let's see if we can get the video to work here. So she's happy with her hand. She's had multiple procedures, but she's able to move it. It's in a good position. She can grasp and squeeze. She couldn't do that before. So not every rheumatoid patient can be treated with an arthroplasty. This is someone who's had multiple surgeries, and this is the last surgery she had was about 15 years ago, and they gave up on her. Said, we can't fix you. So when they land up in your office with a clenched fist that has absolutely no motion, sometimes I tell them that our goals are limited, and it's not possible to give her motion and correction of deformity and a normal looking hand. So with those things in mind, what I landed up doing was to sequentially correct her deformities with fusion of the metacarpophalangeal joints and release of the flexion contractures. And sequentially I did all her fingers, not all at once, but in stages. And eventually she had a hand that could open up and grasp a container or some such object that she wanted to hold on to. She'd never had full motion, but she could at least open her hand and close it. She could hold the canopy up. All right, so this is her most recent picture. She had her last thumb surgery a few weeks ago. So that's what she looks like. So she's very happy with her hand. You know, she can open it, she can close it. She does not have full range of motion, but she's pain-free and she can grasp things. So I hope I've given you, you know, a snapshot of how we correct and treat hand deformities over a spectrum of cases. What I'd like to do is to start off with something on the left and land up with something on the right, like that. Thank you.
Any questions?
Just one quick question. For the skin deformities, especially like the Differential, do you ever use tissue expanders before surgery? Has anybody done that? Why not?
Tissue expansion in the hand is, especially on the farmer side, is extremely, but I'm not even sure to do it. And you don't need much tissue to replace the skin deficits. You can almost always get it from local flaps.
And then what's the long-term follow-up, especially in the rheumatoid, even once you get them function of their hand, does the disease win again, and do they lose it in the long term?
I would say the answer is yes and no. Very often when you put in these silicone joints, over time some of them will rupture. You don't always have symptoms, but they have progressive deformity. But if you, say for example, if you fuse a joint, that's a permanent operation. They never come back with problems there. But they can have recurrent deformity